And then with the advent in 2020 with COVID-19 and the discovery that this virus can exist within the GI tract, the essentially all stool transplantation was stopped in the United States in the manner we've described. But FMT continued in a number of different trials. I did a search just last week at clinicaltrials.gov, and there's 409 trials ongoing at this point, sponsored by a number of pharmaceutical companies for various disease states. And I'm going to pause for a moment to consider these disease states that are being looked at in terms of intervention. On the top line, recurrent C. diff, primary C. diff, COVID-19. Second line, non-alcoholic steatohepatitis, primary sclerosing cholangitis, biliary atresia, portal systemic encephalopathy. Next line, ulcerative colitis, Crohn's disease, radiation enteritis. Next line, immune-mediated diseases such as ankylosing spondylitis, rheumatoid arthritis, Sjogren's disease, psoriatic arthritis. Next line, cirrhosis, liver failure, acute pancreatitis. Interestingly, using an FMT to treat individuals that are colonized with multiple drug-resistant organisms, irritable bowel syndrome, constipation, metabolic syndrome, obesity, diabetes. Some studies have demonstrated ability to modify the metabolic syndrome in obese individuals, if not lose weight. Multiple sclerosis, ALS, Parkinson's disease, autism, Alzheimer's disease, alopecia, another immune-mediated disease, bipolar disease, depression, anorexia, chronic fatigue, chronic renal failure, IgA nephropathy, primary hypertension, immune checkpoint therapy, immune thrombocytopenia, stem cell transplantation, AML, melanoma metastasis, graft versus host disease. So a whole range of illnesses that seem to have no connection at all with the concept that I've been talking about in terms of directly treating C. diff. But I want to give you an understanding of why there's such an interest in all these different. But first, I got to dwell on our experience a little bit longer. With the absence of stool transplantation in 2018, we were approached by a number of pharmaceutical companies, and we were selected as a site to enroll individuals with recurrent C. diff. And this was one of the trials that we participated in. But another trial that we participated in from a company called Ceres, we were a leading enroller. But their product, which is an idealized microbiome that was encapsulated in a gastric acid-resistant capsule and administered, showed that it was gave a statistically significant reduction in recurrent C. diff. And this was just published 2 weeks ago. And I'm going to pause for a moment to go over the concept or the data on this particular trial because it's interesting. And these schematics here show the concept of the study. There are individuals with recurrent C. diff and that occurred as a result of previous antibiotic therapy and had recurrent infections. And for those individuals who met a definition of multiple recurrent C. diff infection, after a final therapy of the acute C. diff infection, they were administered the study product, and it was a placebo-controlled trial. So, half received the study drug, half did not. We enrolled 182 patients, more than 3 C. diff infections in the preceding year, and then their most recent infection was resolved with antibiotic therapy. And immediately upon concluding that antibiotic therapy, this study medication was administered. And it's called the study drug in this circumstance called SIR-109, and it's placebo. It was 4 capsules over 3 days. And these are the results. In the upper left, there was in the placebo group, there was a 40% recurrence rate. A little lower than we expected, but still nonetheless high. And in the individuals that received therapy, there was a 12% recurrence rate, so a statistically significant reduction in terms of recurrence. And the upper right, there was this maintenance of clinical response in the individuals who received the study medication. And the lower left, individuals who are older seem to respond better. but nonetheless, across all age groups, there was a statistically significant improvement in terms of response. And in the lower right, it depicts the response depending on the particular antibiotic, and it was significant response regardless of whether they had received vancomycin or fidaxomicin or dificid. Now, this is particularly useful because it shows that after the transplantation, shown in dark green, there was persistence of the species that were being administered. So not only was there a response, but it was demonstrated that you had a persistence of the microbiome of the study drug that was administered, and it persisted on, and that this new microbiome on the upper right, or the right rather, shows that there has actually been a change in the metabolism of bile acids, which shows there's a sustained metabolic effect of this transplant. So safety outcomes, there really weren't any there were some gastrointestinal symptoms like bloating and constipation, but it was no different than placebo. And then finally, this just reinforces that there was persistence of the dose species contained within the study drug. And so it represents, it persisted, but it also blended with the recipient's microbiome. So we can see that the microbiome replacement therapy was effective in this circumstance, and the particular company is applying for application for clinical release later this year. So it's exciting for us, but I just wanted to pause for a moment and just show you the slide once more of the microbiome as it interacts with the gut epithelium, and to re-emphasize when you do a stool transplantation, you're not just changing the species, you're changing this ecosystem, and you're trying to normalize this activity. And the other point I wanted you to draw from this is that there is an interaction with the immune system, and that the immune cells can have effect distantly from the area of local interaction. This is just a very busy slide. It shows the upper portion a healthy, an individual that's unhealthy, microbiome has been altered in various disease states, and then the lower, an individual that is healthy, microbiome stable, and in these tiny little letters, words in the lower end, there's a number of modifiable states that can influence the microbiome. Some things you can't influence, your gender, your inheritance, and then in terms of host physiology, you can't influence that too much. Things like diet or antibiotic use or environmental exposure can make a big difference. And so that's a particular point in terms of questioning, well, what should I do to stay healthy or have a healthy microbiome? And oftentimes it comes down to just doing what your mother told you to do, eat more fruit and vegetables, and trying to take in a little less protein and less processed food to make the biggest difference. Inevitably, people ask me about probiotics and prebiotics, and again, there are limitations on those recommendations based on what I've just said before. So coming back to this, there are just a few more slides, and this is a study that was just published this past few months in Gastroenterology. That's our main journal. And I'll just read the top. Prolonged impairment of short-chain fatty acid and isoleucine biosynthesis in gut microbiome in patients with COVID-19. This is a study out of China, from Hong Kong, and it was noticing that individuals subsequent to an episode of COVID-19, that there was a profound change in the microbiome in some individuals, and that change was associated with reduction in certain metabolites being produced. From left to right, an individual's hospitalized, they have an inflammatory disease state, it releases inflammatory mediators. It seems to, in individuals with COVID-19, in their and when they're hospitalized, the microbiome changes profoundly. There's a reduction of critical metabolites that are beneficial, and then subsequently that microbiome recovers, but in some people it doesn't recover as readily as others. And then the subsequent study, also reported from China, from Hong Kong and another center, looked at this in a more or less retrospective study. Looked at individuals who were hospitalized with COVID-19, none of whom had received antibiotics before hospitalization, and they looked at the disease course. Those in the upper left had a mild to moderate course. Those in the lower left had a very severe course. And in all of them, there was an alteration in the microbiome during their hospital stay, with reduction in certain key metabolites. And then subsequent to discharge, there was recovery in those people, in all of them, in terms of viral clearness. But in some individuals, those with a severe COVID-19, their microbiome did not recover completely. And in them, they're more likely to have a prolonged COVID-19 syndrome or prolonged COVID syndrome. And now studies are looking at this in a prospective fashion to see if individuals with an altered microbiome upon admission may be more susceptible to a more severe course, and whether an intervention can occur in an earlier fashion to mitigate or moderate the intensity of disease state. And at least in mouse studies, as a result of this immune stimulation in the mucosa, it can inhibit the ability to fight off viral infections, respiratory viral infections, when these mice are exposed to concurrent with an inflammatory state in their GI tract. So in a little more detail, and we have the left, a SARS-CoV-2 virus capitalizes on the angiotensin converting enzyme receptor, which there is a large number within the GI tract, and with interaction with this receptor on the surface, it blocks the normal interaction with the angiotensin, and then as a result, there you can get an alteration in the permeability of the GI tract, or the gut epithelium, concurrent with a change in the microbiome. And these two changes, lead to further ingress of inflammatory mediators, bacteria, across the epithelium, leading to an inflammatory cycle and the circulation of these immune cells throughout the entire body. And that, if that microbiome does not recover on the recovery stage, what can then occur is that you have continued inflammation, continued circulation of these inflammatory immune cells and cytokines that can affect the rest of the body in terms of function, as well as CNS function. This has been looked at. This is a question that came up before, and in some individuals with chemotherapy, some people respond better, other people don't, and that's been linked to an alteration in the microbiome in a prospective fashion. Those people that have a dysbiotic microbiome don't seem to respond as well to certain chemotherapy. And so that's a current trial right now, looking at whether microbiome can be influenced before a course of chemotherapy to enhance response to chemotherapy. So I just want to stop there. A lot of slides, a lot of information, but I wanted to leave you with the concept of microbiome as being an active organ that actually is beneficial to the host, plays a key role in terms of protection from pathogens and in regulation of your immune system. And more than that, though, it provides us sort of a new paradigm in the last 15 years as a way of approaching various disease states and having another means of being able to intervene. And particularly now, if we can get a standardization of a FMT product, we can look at a number of these disease states in a more systematic fashion.